I'm delighted to introduce Matt Fay, who is a colleague from the Primary Care Cardiovascular Society, so a fellow council member. And I'm sure many of you will be familiar with all of the work that he does around cardiovascular disease. He's a GP specialist and also has a keen interest in thrombosis. He previously worked at Affinity Care, which was one of those super practices that we hear about. Not all of them are super beyond their size, but Affinity Care did some incredible work with the 27 partners and 64,000 patients that they were working with in Bradford. And he was instrumental, key in developing the Bradford VTE pathway. He's also been involved in the redesign of various services across primary, local and national levels. And I know that I personally have gone to him far too many times, I'm sure you would agree, Matt, to ask him, what do we do about this? And have you got a pathway on that? And can I share this pathway with people that I'm presenting a webinar to? And he's always said yes. So really supportive of sharing the knowledge throughout the UK and amongst colleagues. So Matt is actually a trustee of Thrombosis UK, and he's going to start us off exactly where we need to start, which is improving our early suspicions and going on to make the diagnosis of thrombosis. So thank you, Matt. Over to you. Matt, I can't hear you at the moment. So I don't know if that's just me.
No, I can't hear Matt either.
Okay. That's funny because we could just hear you very, very clearly.
How about now?
Yeah, oh, yes. There we go. Perfect.
Zoom had reset itself a little bit, so apologies for that. And anyway, Bev, I was just saying that I'm always happy to take that one more phone call from you about any topic. So let me just share my screen. Bev, can you just confirm you can see my slide?
Certainly can.
Brilliant. So it's a pleasure to be invited to talk about the diagnosis of VTE. It's a topic very close to my heart. I really feel that we need to be considering VTE at those doorways to the NHS and healthcare, whether that be primary care in the general practice setting or in the ED. We need to be thinking about VTE, and I'm going to try and expand on why that is, and hopefully come up with a bit of a solution for us. So just to quickly go through my declarations, my partnership has received payment from various companies. I'm not going to touch on any of this today, to be fair, and I'm an advisor to several of the national cardiovascular and thrombosis charities. Now, we're going to get onto a message today, and it's very, very rare that you get this on a cardiovascular society slide in a positive light. So today's take-home message is going to be chips, okay? And we'll get to why that is. I also need to thank our friends at NHS Resolution, who are also doing some fantastic work around VTE. They've been very kind to lend me their slide deck, so I've been able to take a few of their slides from this fantastic pack that they put together. The web link is on the bottom of the slide there, but if you just Google NHS Resolution and VTE, it will take you straight to the landing page for this fantastic deck. Now, why should we be thinking about VTE? And this is an oft claimed fact, which is that 40% of people who actually die of a pulmonary embolism have actually been to see their primary care clinician or an ED clinician in the weeks prior to their death. 40%. Now, that is quite an alarming figure when we consider that we should be suspecting things that could cause our patients harm. And if we're not thinking about a condition which presents as sudden death in 1 in 4 people, then are we doing them the service that we should? Now, how does this work out within the NHS system? And this, of course, is why NHS Resolution are also involved. And that is because when these incidents occur, then the NHS can be seen to be liable. So therefore, the NHS Resolution becomes involved because of the claims of negligence against the NHS. And as you can see, there are substantial numbers in the last 10 years. There are substantial numbers of people who've claimed against the NHS where they feel that the VTE event that they suffered was identifiable from their initial presentation, and they have come to harm through the fact that people have not noticed or have not clicked to the fact that their issues were around VTE. So this leads to the obvious question: how do we identify somebody presenting to our ED or to us in general practice as suffering from a VTE? Now, of course, they could come in and say, all my relatives have VTE and I'd have similar symptoms to the last one of them. Now, that is fantastic when this occurs in general practice. Unfortunately, after my 25 years in general practice, I can't remember many people coming in and saying, doctor, I think I'm having a thrombosis. But one thing that I did realise is that you're not going to spot somebody who might have a thrombosis unless we think that they could have a thrombosis. And we have to keep that thought in our mind all the time. The same way that when we see that smoking male coming in with various symptoms in the chest, we immediately twig to the idea this person could have cardiovascular disease. Could this be their heart? And that seems a very ready idea to spring to mind whenever we see a certain category of patients, that we immediately think that that could be a cardiac event. But are we doing the same for thrombosis, particularly when both myocardial infarction and pulmonary embolism have that thing in common, that their presenting feature in 1 in 4 people is sudden death? So we need to be thinking of thrombosis because that's the only way we're going to spot the signs. And NHS Resolution, their pack, have done a lovely slide pointing out the symptoms and signs that could be a pulmonary embolism or a DVT. Now, one of the things I would really like to pull out of their list is that unilateral symptom in the leg. So somebody who presents with pain in one leg or swelling in one leg, or redness just of one leg, that is the time to start thinking, could this be a VTE event? Could this be pulmonary embolism? And maybe start to put a risk calculation in your head, run through a Wells score in your head around that. However, those of us working in general practice for some time will say, well, people with achy legs are common. It could be osteomalacia. People with redness in their skin, particularly older people, particularly people with varicose veins. Well, we see a lot of redness in the skin. What about the pain and the swelling? We've got, because of our big push on hypertension, we've got so many patients on alpha blockers and dihydropyridines. Of course, a little bit of puffiness around the ankle is common, but all those things have one thing in common, which is that you'd expect them to be bilateral. So when you see that unilateral leg, you should be thinking of of DVT. And of course, PE, one of those things that we all worry about because the symptoms are so bland, and pain in the chest or upper back. I mean, how much of that do we see? Shortness of breath, particularly during the pandemic that we've just come through, dry cough and shortness of breath, that was everywhere. And so, these are common symptoms with lots of different diagnoses. So how can we think about it? And what I'm going to suggest is that in this situation, we may want to choose chips. Okay, and what do I mean about choose chips? Well, think of the symptoms. So a cough, hemoptysis, only one leg affected. There's edema in that one leg, shortness of breath, erythema of the skin in one leg. And what do we get from that? We get chews. Then think of the risk factors. Cancer, active or in its palliative stage. Hospitalisation in the previous 4 to 6 weeks. Very important. Remember that a third of all VTE is hospital related. So where we send our people to get better and to receive active treatment is a risk factor for VTE. And of course, we see that in our VTE assessments within the hospital, but it's really important to think of those people who've come home from hospital, getting themselves going again, who have got one of the CHOOSE symptoms. Have they been hospitalised? Have they had immobility? Have they had a pot on? Have they broken a leg recently? Have they been in bed? And what we're talking about with immobility is only 3 or 4 days. It doesn't have to be much. Is there a previous history of VTE? As soon as you see that on the record, that should be getting the grey cells churning over, thinking, could this be there again? And pregnancy, of course, and when I say pregnancy, I'm including the postpartum period, where we've got to be suspicious. And you don't do a Wells score, you don't do a D-dimer on people who their risk factor for VT, they've got a CHOOSE symptom, and they've recently been pregnant or they are pregnant. You don't do a Wells score on the pregnant. They require assessment with our colleagues in the hospital. So move these people along. And is there a family history? The patient may volunteer this. They may say that, like, one of my relatives has that weird thing, that von thing, and you fill them in with the von Willebrand. We may need to draw that out of our patient. But is there a family history of people with VTE? So have they got a CHOOSE symptom? Have they got a CHIPS in their recent past? And if we get CHOOSE CHIPS, we need to be thinking of thrombosis. And if we think of thrombosis, we'll spot it. Of course, that's an oversimplification. And of course, there's other risk factors as well. So of course, we're going to see more VTE in the older population, the people who are overweight. Don't forget heart failure. We've got a big focus within the PCCS around heart failure with all these new therapies coming online. But remember that that person could be getting more breathless with their heart failure, not because their heart failure is worse, but because they're throwing off emboli. So think about thrombosis in these settings. So yes, CHOOSE CHIPS isn't everything, but at least it gets us moving. And what about those transient factors? And we're going to hear later about HRT, so I'm not going to move on to that, but think about the oral contraceptive. The first significant PE I saw back in the 90s when I was starting my training was a woman on a 3rd generation pill who was a smoker. And we nearly missed it. But she would have come to incredible harm if we'd let her go out the hospital. But back in those days, of course, we got her on her IV heparin. I've said all that, and I've made it seem so simple. PE and VTE is one of those diagnoses which are very easy to get in retrospect. So when somebody comes in and they've had a bit of breathlessness and a cough, and you think maybe they've got a chest infection, and you get told by the receptionist the next day that they're now in hospital, and you think, it was a PE. The retrospectoscope is very useful when it comes to VT and PE diagnosis. This is not an easy diagnosis. 50% of those people presenting with PE have breathlessness, same way that 50% don't. So we've not got that positive, strong symptom that we have with cardiac disease, of a central crushing chest pain radiating to the jaw and the arm. We haven't got something like that for PE. The symptoms can mean so many other things. But if we think, could this be a PE? And we start to do a risk assessment, that's how we will spot people. If we think about thrombosis, whenever we see somebody with leg symptoms or chest symptoms, and we think, could this be a thrombosis? We will get much better at spotting it. Does that mean we have to admit all these people to hospital? I can, even on this webinar, I can feel my colleagues in ED having kittens about the fact that all these people are just going to be ushered off to the ED department, and I appreciate that they're already working very hard and very busy trying to spot this themselves with the people who just walk in. And this is where we have to think about what is our next step. And the next step, of course, is to do some form of risk assessment, and the risk assessment, which is endorsed by the NICE guidance, of course, is the Wells score. So when we think, could this person have a thrombosis? We've thought choose chips, we think thrombosis. What should we do next? Well, we should do a Wells score, and we should work through that Wells score to see if we should be sending this person on. Remember, if somebody has a high risk score, so a DVT score of 2 or greater, a P score of 4 or greater, then we should be doing an exclusion scan on these people. These are not people who would have a D dimer. These are people who would require actual scanning according to the guideline. Now, one of the things you immediately notice about the Wells score is the difference between PE and DVT, where if you think that somebody might have an alternative diagnosis, you remove 2 points in the DVT Wells score. And that is if you've even done the score. Now, I'm going to suggest that you think it's a DVT because you've actually done the Wells score. So it's not going to be common that we remove that. And of course, in the PE Wells score, if you've thought this could be a thrombosis, that immediately gives you 3 points. Okay, so that gives you 3 points on a score which is positive at 4 points. So you don't need many more risk factors. Active cancer, recent hospitalization, but you've thought it could be a PE, and therefore you should act on that. And what could we do beyond that? Well, of course, that's when we get to the often quoted PERC score. Now, PERC is a useful risk assessment, I would suggest, in the hands of the expert, less so for those of us in general practice who may see 1 or 2 potential thromboses a year. I think we need to be cautious about using the PERC score. And one of the reasons for that is if we look at PROSPER, what PROSPER showed us was that PERC did help, but in a low risk group of patients. So if you've already done your Wells PE score and they have a score of 4 or more, then PERC doesn't have much to offer you because these are not a low risk patient. So this is a way for people to help those lower risk patients who may or may not have a PE by looking at other factors such as their heart rate and so on. So I would suggest to you that PERC isn't a general practice tool. It may be in out of hours and our colleagues in urgent care, definitely, but I'd be cautious of it in general practice. Bev was so kind to talk about my practice that I left in the middle of last year. And this is the pathway that we came up with to try and see if we could become more astute at catching people who might have a thrombosis, which is to choose chips and think thrombosis. And if you think about it, do a risk score. If they've got a high risk score, as we've already said, they require imaging to remove them from the pathway. Otherwise, we started doing point of care D dimers. So the fact that you thought about a thrombosis, to exclude that person from a thrombosis pathway, even with a low risk score, we were doing point of care D dimer to try and help us work that out. Why? Because if you've got a low risk score and a negative D dimer, you can sit back and be assured that the chances this person has a PE, a thrombosis, are very small. What does NHS Resolution say about the D dimer? And again, it comes in saying we should be using D dimers. We should be looking at how we can bring D dimer into our ED, into our acute setting in general practice, because D dimer does have a place to play because of that negative predictive value. So if you've thought somebody might have a VTE event and you risk assess them, they're not high risk, but you thought about it, then a D dimer is a useful tool to try and help you eliminate a thrombosis, to reassure both yourself and the patient, and of course our colleagues in NHS Resolution, knowing that we're excluding VTE events. If we've got somebody who seems low risk, their symptoms don't seem that progressive. Is that fine? Should we just let them go? And of course, the answer to that is, well, we can always be wrong. So make sure you've safety netted the patient. Make sure that they understand what could happen if this is a PE event or a VTE event, and what they need to be watching out for, so they know when to come back to us. Because it may not seem that likely at initial presentation, but given another 48 hours, things can change. So it's really important to safety net our patient to make sure that they know when to return. And what about thrombosis in the patient? Make sure we talk to our patients. Okay, we may understand thrombosis. I was recently in hospital and had a VTE risk assessment. I had no communication from the staff as to what they were up to. They were just injecting me in my tummy and put my stockings on. It's really important that we educate our people about thrombosis, because if our patients don't know about thrombosis and we don't think about thrombosis, we're going to continue to miss this. And it's really important that we don't miss this. So have a conversation with the patient about what a VTE is, why they should be keeping an eye open for it, and of course, if they suffer a VTE event, when they should come back. And of course, how else can we support our patients? We can ask the team at Thrombosis UK to get involved. So I make sure all my patients who have suffered VTE events are aware of Thrombosis UK and can go there for assistance. So in summary, we've not had great education in general practice about DVT and VTE. It's a swollen leg. Well, actually, the commonest symptom that we will find with the VTE is unilateral pain, calf pain. So don't be just thinking it has to be a swollen leg. Think about VTE if you've got somebody with a unilateral, uncomfortable leg with no clear reason, and then work through our risk score. We've got to keep talking about it. If you're listening to this conversation, then please go back to your practices and talk to your colleagues in general practice about it. Point of care D-dimer can be useful. Make sure your pathways are simple. Make sure the intervention is symptom, and always keep the patient informed. So my take-home message of today is choose chips. Most of us do that anyway when we're out and about. What I want you to remember is choose chips. When you see a patient, do they have symptoms suggestive of a VTE? Do they have a history which could lead to a VTE presentation? So choose chips, and hopefully that way we will keep away from NHS Resolution, because we make the diagnosis, we look after our patient, and we stop them having VTE events. Or if they do suffer VTE events, we spot them very early and make sure that harm is minimized. So choose chips. Thank you very much.
Thank you, Matt. What a great message. Not one we're going to forget, is it? Choose chips. As you say, we don't hear that for so often with a cardiology bent. But we have got time for a couple of questions. There are no questions that have been asked at the moment. So if you do have questions, do pop them in the Q&A box, and we can try and answer your questions. If not now, then towards the end of the session. But it's just really, I wanted to really think about the role of the non-doctors amongst us, because I think as more and more nurses, paramedics, pharmacists are doing that first contact type of work, it's a very, very salutary reminder that we should be thinking thrombosis when we see people with some of these, relatively vague symptoms. And as you say, it's hard to spot, but history is the basis of everything that you talked about there. So we're brushing up on those skills, I think, is key. So
I think the major thing, Bev, is we enlarged our workforce, and to be fair, general practice is not the greatest at spotting VTE anyway. And so as we're enlarging our workforce, bringing the pharmacists in, the paramedics in, a load more ANPs are coming into the system. We need to bring about that real shift in the fact that we think about cardiac disease, we should think about VTE. And the same way as we do with cardiac disease, that we do that risk assessment in our head, is this a diabetic? Are they hypertensive? Are they a smoker? We move that then to say, have they been hospitalized? Have they been immobile? Could this be a PE? And that is how we're going to get better at this. 1 in 4 people, the way their PE presents is sudden death. Just the same as an MI, but we all got taught about MIs all the way from our first year of medical school. PE seems to have got lost a little bit.
Yeah, and post-COVID, of course, it's been a bigger problem because of the virus being a pro-inflammatory, pro-thrombotic type of virus. So even more reason to be aware. We're not out of the woods yet with COVID, are we?
Yeah. And I think it's interesting running an open echo service as I do in my cardiology service, the amount of people who have unexplained pulmonary hypertension, they've never smoked, they've got pulmonary hypertension, then you take that history and you find 3 or 4 years ago they had that sudden onset breathlessness where everything suddenly changed and it was put down as a chest infection, but it took weeks and weeks to resolve. And of course what it was a thrombosis, and it was just waiting for the lung to collapse and the rest of the lung to fill that space. So it's an often missed diagnosis, sometimes presenting unfortunately to NHS Resolution when people have come to real harm, but frequently I would suspect people it's just missed and they come to accept life in a post-PE world.
Yeah, which is a real shame, isn't it? It's really interesting to think of the role that NHS Resolution has in, thinking about the fallout of when a diagnosis hasn't been spotted. So another warning in that respect.
But the other thing as well is they know what gets us into trouble, so they're out there trying to educate us to stop us making the same mistakes again. So thumbs up for NHS Resolution on this occasion.
Exactly that. Well, thank you so much, Matt. There's already some comments from people saying thank you so much for an informative session.